The asbestos issue is not a thing of the past. It continues to this day.
We want to end this man-made disaster.
So let's ban asbestos.
Thank you. Usually it's the disadvantage to be the last speaker because there's no time, but because of the way that Linda runs these conferences, I may have a little bit extra time, I'm not sure. While they're loading up my PowerPoint, I'm going to talk about lung cancer. And we mostly focus on mesothelioma because it is the hallmark disease for asbestos exposure. It is the signal. It's uniquely related to asbestos exposure. And obviously lung cancer is not. Lung cancer has another cause besides asbestos, which is more common, cigarette smoking. But there are also other occupational causes of lung cancer: diesel exhaust, beryllium, silica, and others. So I'm going to talk about lung cancer, and it's going to be directly relevant to asbestos exposure, but also beyond that to the other occupational lung carcinogens. Lung cancer is as dismal a disease really as mesothelioma. We hear less about it, but in terms of what happens to people, in terms of how long they live, it has as poor an outcome up till now as mesothelioma does. What I hope to convince you in the next 10 or 12 or 15 minutes is that we can now screen for lung cancer, we can detect it early, and we can cure perhaps not all lung cancers, but many lung cancers as a result of early detection. And the fact is, of all the asbestos diseases, lung cancer is the only one in which we can say this about now. There is unfortunately not early detection routinely or on a systematic basis for mesothelioma. There is early detection for asbestosis, but not a lot of ability to interrupt the progression of asbestosis. But for lung cancer, in fact, we can do this, and we can do this now, actually. Lung cancer is epidemic, not just in the US. I give US statistics here, but it's epidemic across the world for reasons that you know. It's epidemic both among women and among men. In the US, among women, it's the leading cause of lung cancer. In fact, it is more common than if you combine the next two most common causes, breast cancer and colorectal cancer. Among women and among men, you have to go actually down the list, the four next most common, to match the sum of lung cancer. It's also the leading cause of cancer occupationally. And there's been a couple of slides that have touched on this. In Germany, Dr. Rossler showed a slide where mesothelioma was slightly more common than lung cancer. And that's because lung cancer simply isn't well recognized as being work-related, even among asbestos workers. And if it were truly recognized, actually, the numbers would show that it's more common than mesothelioma. And the reason why lung cancer is lethal is because it's almost always, until now, diagnosed at a late stage. So the typical story is a person who has had exposure in the past, asbestos, smoking, or the like, presents to the physician, coughing up blood or short of breath. The physician does a chest x-ray, they do a CT scan, and they find a big mass in the lung. And that's advanced disease at the time of diagnosis. And so only 15% up until now of people with lung cancer are diagnosed at an early stage. Therefore, very few people survive lung cancer because when it's diagnosed at stage 3 or stage 4, there's actually very little that can be done. Usually it's not surgery. Now for stage 3, there are some very expensive drugs that are used which can prolong life by a year or two. But in general, people with advanced lung cancer do very poorly. Yet we know that, and we've known for a long time, that if you diagnose lung cancer early, you can actually cure people of the disease. And I want to give you an example. I had a professor, I trained at Mount Sinai under Selikoff, and there was a professor in the unit who used to smoke, and this person went to a conference in Eastern Europe. It was an asbestos conference, and ended up falling and bruising his or her chest and ending up having an x-ray. And actually this professor was one of the top x-ray readers at Mount Sinai, in particular for asbestos disease. And so this person insisted on seeing the film. They said, okay, there's no rib fracture, that was the concern, but In fact, he insisted on looking at the film and looked at the film and said, I agree there's no rib fracture, but what's behind that? And what's behind that, he used to smoke a long time ago. What was behind that was a very small lung cancer, detected early, removed through surgery, limited surgery. And fortunately, that professor was around to teach me a little bit about asbestos-related disease. But those are the circumstances up until now in which lung cancer has been detected early. Well, we can do that, not accidentally now, but we can do that systematically. And I credit here Dr. Henschke from New York City, Cornell, 1999, publishing the first study for us. But frankly, it was a technology transfer engineered by the Japanese, because Professor Son from Japan published similar results in 1995 and probably gave Dr. Henschke the idea here. And what she demonstrated was that you can take, in her case, a high-risk group for lung cancer, smokers, age 60 and over, and you can detect lung cancer, and most of the time you can detect it early using a low-dose CT. Low dose means low radiation dose. So this was published in July 1999, and we, where I worked at City University of New York, we were running a medical screening program with the United Steelworkers and other unions for nuclear weapons workers across the country. And so we were screening with X-ray, with spirometry, breathing tests and the like, for emphysema, for asbestosis, using what was available at the time, nuclear weapons workers, many of whom had been exposed to asbestos, but were also exposed to radiation, some to silica, beryllium, and all those are lung carcinogens. And so we read that article, and this is where our program still exists across the country. Not really in New York, but for those of you not familiar with our geography, in the Midwest, Ohio, Kentucky, Tennessee, and also out in New Mexico, Idaho, Nevada, and California. And so we were running this program, and we decided that this is what we needed. Actually, it was a month later after the study was published, we approached the Assistant Secretary of the Department of Energy, a guy named David Michaels, who agreed with us and gave us initial funding, and so we started CT screening for lung cancer among these workers. And this was our scanner, and I use this example because it shows that this screening really can be done. I mean, it's been done, and we can do it not just for these workers, but for asbestos-exposed workers in the future. This was our scanner mobile unit that we took to various places, and this was our opening in the year 2000. I just want to point out there's David Michaels, who gave us our initial funding, now head of OSHA. And to David Michaels' right was the champion of our program, Senator Mitch McConnell. This was probably the last time they were seen together. Certainly it was the last time they agreed on anything, but Senator McConnell has supported our program. And this is now we have an additional scanner. This is in Oak Ridge, Tennessee. And that, by the way, behind it is the Union Hall, because this is a union program. And so I'll give you a couple examples of what I'm talking about in terms of low-dose CT. This was a woman who worked in one of our facilities in Oak Ridge, Tennessee, also a cigarette smoker. And so we did the regular X-ray on her, the conventional film. It doesn't show great on a PowerPoint, but the black areas are her lungs, and you don't really see any white spots, white masses on either side of the chest. But if you do, and in the middle, by the way, is a heart, which is normal. But if you do a CT scan, and this is very high up in the lungs, so the lungs look kind of small, and you look at the blackened areas here, which are the lungs, and by the way, this blackened area here is her windpipe or trachea, but you see on the right a lesion, a mass, right? And this is our ruler. Each of these gradations is a centimeter, so you can see this is a small lesion, and that ended up being a lung cancer. That's how obvious it was on the low-dose CT scan. And it was in a location, I'm very fortunate for her, that it could be removed without taking out a lot of lung tissue. And so she went to surgery. This is stage 1 lung cancer, went to surgery, and has done fine. Here's another example, another person who worked at one of our Oak Ridge facilities. I'm not going to show you his regular X-ray, I'll just show you the CT scan. This is a slice of the chest. And yes, we have a board-certified radiologist who reads this for us, but actually, we don't need a board-certified radiologist to see the lesion here, which is on the left. I don't show you the ruler, but again, this is a small lesion. And you can't see this on a chest x-ray, but you can see it clear as day on a low-dose CT scan. So for all the fancy technology, the imaging is actually very straightforward. And so we've continued this work, and we've screened now 12,500 workers with these two scanners. And among those 12,000, we have detected 102 lung cancers. That's about 1 out of every 123 people that we've scanned. But most importantly is what stage did we detect them at? Because if all we were doing is detecting lung cancers late, we weren't helping people. And so our stage 1 is the earliest stage. It's a small lesion, hasn't spread, can be removed through surgery. About 60% of the time of all of our lung cancers detected were stage 1 disease, and an additional 11% were stage 2. So 2/3 were early stage disease. These are not quite as good a results as Dr. Henschke had, but this is, in general, what the findings are across the study. So we were able to show that not just at Cornell in Manhattan, or not just at Dana-Farber in Boston, but in Paducah, Kentucky, and in Portsmouth, Ohio, and Oak Ridge, Tennessee, among a workforce that had exposures and was highly motivated, that you could do the same thing. You could have a low-dose CT program, find lung cancers early, people would come, and people would benefit. And so what Dr. Henschke then continued her work, which also includes, we are part of her consortium, and she found just a few years ago that not only can you detect lung cancer early, but that the people detected do very well when they undergo surgery. So this was the next important finding, published in New England Journal in 2006. And then the final study, and this is the study which is actually going to determine what the policy is, was the National Cancer Institute study. Frankly, I think Henschke embarrassed them in the year 2000 into doing a randomized controlled trial, a bigger study. This NCI National Cancer Institute study, 50,000 people, cost $250 million, and they ended the study early because they found a beneficial effect. And what they used 25,000 people got low-dose CT scan, they were smokers, and 25,000 people, also smokers, got just a regular chest x-ray. And then they gave them an annual scan or x-ray, and then they followed them for a few years. And they found out that the people with the low-dose CT died less often than lung cancer. And at the time they stopped the study, there was a 20% mortality benefit. That will go up over time. But they had to stop the study. As soon as they found a benefit, it wasn't ethical to continue the study. They stopped it and broadcast the results. And so December 31st, 2013, just in time, the United States Preventive Services Task Force, and they're the group, the federal group that takes studies and decides essentially what the U.S. government policy will be. They endorsed low-dose CT screening for the first time ever, an effective means of detecting lung cancer early. They did that December 31st, 2013, and what that meant was, under the Affordable Care Act, that the insurance companies would have to cover this as part of their policies. They would have to offer this to people in their plans. The problem is the U.S. Preventive Services Task Force only mentioned that it was useful for smokers. And the reason they did that, the reasons are probably complicated, but regardless, the fact is they just used the entry criteria for the National Cancer Institute. They said, that's our study that we can rely on. We're only going to make that group eligible for screening. So is there any mention of asbestos, beryllium, silica, family history, or any other risk factor of lung cancer? And the answer is no. Problematic, but actually what that means, though, is that that's work for us to do. Because with our knowledge, then, we need to move ahead and make lung cancer screening happen for asbestos-exposed workers and others exposed to asbestos and the like. So the knowledge that we need to look at is that, first of all, CT scanners are universally available. Okay, low dose simply means having the technician dial down the radiation dose. But it's the same scanner that we have everywhere. So this is an accessible, available technology. You need to know the discussion about how much radiation dose there is it's low dose and it's dropping all the time. And so if you had that test annually for 30 years, would that, beginning age 50, would that increase your risk of lung cancer? Yes, it would, by a very small amount. And that's why we reserve the test for people who are at high risk of lung cancer otherwise, because the benefits would outweigh the risk there. And it's not recommended for the general population. The third thing we need to understand is, you'll hear a lot about this because this is what the newspapers cover. There are all these false positives. These scanners, when you look at the lung, they find nodules everywhere, and we can't tell the difference between a lung cancer and these other nodules, and we're causing tremendous amount of anxiety and unnecessary surgery. And that simply is not true. So she's holding up the sign that says the next speaker, but I know that the question and answer period is next. Anyway, so the false positive problem, the way we address that is, a lot of people, like 20%, will have nodules in the lung. They're not cancers, they're nodules. And we repeat the low-dose CT scan in 3 months or 6 months. And if they haven't grown, and they almost always haven't, then we can say, fine, that's not a cancer, come back in a year. That's the way you deal with the vast majority of positives. If it looks like a real cancer, of course, they go off to see the pulmonary physician. And the insurance companies are going to be beginning to pay for this. So what we need to do is to have people tell their physician that they were exposed to asbestos, because that doesn't happen. The physician doesn't ask. For those of us in the room, like David and Chris and others, who testify in court and review medical records for people who have mesothelioma even, or lung cancer, more often than not, those medical records don't say anything about the asbestos exposure in the past. Sometimes mesothelioma, there's maybe a one-liner, but I can tell you on lung cancer, it's almost never there. The smoking history is always there, but the asbestos history is never there. So that means that people have to tell their physician, you know, I work with asbestos, I was exposed to asbestos, how about a low-dose CT scan? And then seek out the right place to do it, because you know, there are a lot of places now in the US offering low-dose CT, a lot of high-quality places. The Lung Cancer Alliance on their website lists a couple of hundred high-quality places, so that would be important. So then let me close by saying, yes, we can now screen for lung cancer. We can detect it early, and in many cases, we can cure people from lung cancer. Thank you.